afternoon, everyone. So my name is Yvonne Nartey, and I'm a senior research associate at the University of Bristol. And I'm coming to present on some of the work that we are doing in the NHS secure data environment, looking at the benefit and harm of directly acting oral anticoagulants during the COVID pandemic. So anticoagulants are medications that are usually used for prevention of stroke in individuals with atrial fibrillation. They are also used for other conditions like people who have deep vein thrombosis and then other rare conditions as well. So for decades, warfarin has been the main medication that has been used. But over the past few years, it has been replaced by a new class of medication. And this is mainly because warfarin has a number of limitations. So the dose of warfarin in an individual blood is influenced by a number of factors. So individuals have to frequently go to the hospital or the GP practice to monitor the level in their blood. Okay, so we indicate that it has a low therapeutic index, meaning that the amount that is required for it to be effective and the amount that is required for it to be toxic are very close together. Additionally, it is also affected by change in diets, alcohol use, and then when people are ill or if they are taking other medication as well. Okay. And so due to the limitation of warfarin, a new class of medication have been introduced, which are the directly acting oral anticoagulants. And these medications, they do not have some of the limitations associated with warfarin. However, there are concerns in terms of their safety with bleeding because we have limited or low dose of other choices that we can use, and some of them are also very expensive. So when you are looking at DOA, you can think about apixaban, rivaroxaban, endozaban, and then dabigatran. Now, when you compare the efficacy of DOAC with warfarin, they are not inferior with warfarin. Previously, during the COVID pandemic, there have been a lot of changes in the use of DOAC. Okay, and DOAC has been used for the treatment of individuals with who are infected with COVID. Additionally, because of the need for monitoring for warfarin, people are switched into DOAC as well. Again, during the COVID-19 pandemic in 2022, NHS England did a procurement exercise, and they came out with a recommendation that significant changes can be made if individuals are switched from all DOAC to endozaban. Later on, apixaban came off patent, and this indicates that switching from one medication to the other is not a means of a cost-effective mechanism. However, it actually raised the question of how effective are these DOAC when you compare them to each other, and then also with warfarin. Additionally, looking at some of the limitations associated with in terms of bleeding, the side effects in terms of bleeding, we've not had a look at that. And then also looking at the cost effectiveness of this medication as well. So our study was hoping that we will be able to answer those questions in our study. So now, the first thing that we decided to do is to look at quantify the use of DOAC during the COVID, before and then during the COVID pandemic. Okay, so we do that looking at the various, like in terms of the GP practice, and then also data from hospital practice, and we stratify that by age, gender, and other indicators. Then we will use the target trial emulation framework to compare the efficacy and safety of these 5 medications. And in terms of efficacy, we are going to look at how effective they are in preventing ischemic stroke in individuals with atrial fibrillation. And then in safety, we are looking at a major bleeding associated with this medication as well. And then we'll move on to look at the cost effectiveness of these 5 medications. And so this is our research questions that we have. Okay, and so this work is being done in the NHS secure data environment. So we link various data sources, including GP practice data and medication dispensing data and other data sources to create our cohort of interest. So a little bit of some of the work that we've done so far. We've looked at the incidence of atrial fibrillation from late 2019 to December 2024. And we could see that there is a dip in the incidence during the COVID pandemic, and then it starts increasing. In terms of the medication dispensing, this goes with this literature. So you see that apixaban is the most common medication that is being prescribed. And then you could also see that after the NHS recommendation, a NICE guideline has changed. You see that endorsement has picked up. And then later on, all the medication, they start dropping up. And we think that maybe individual may be opting for other intervention like surgery. When you look at the first line of treatment based on region, there are variation based on a region of residence. So apixaban is more common in the northeast, and then it's less dispensed in the east of England. Then when you look at endosaban, endosaban is mostly prescribed in the northeast, east of England, and least prescribed in the northeast as well. You see that the use of dabigatran and warfarin, they are very minimal across the regions as well. We also look at variation in terms of various indicators, and you could see that females are less likely to be prescribed any of the 5 anticoagulants compared with male, and this could be due to the fact that maybe there is underestimation of stroke in female or overestimation of bleeding risks in female as well. And then in terms of age, you see that people age 90 and over are also less likely to be dispensed anticoagulants. And we think this may be due to risk of bleeding and frailty as well. There is also variation in terms of various ethnic group as well. And we think this could be due to a number of factors. Okay, so we could look at maybe access to healthcare. Also, some ethnic group may be prone to other comorbidities, which may prevent them from being prescribed some of these anticoagulants as well. And you could see also there is variation with what IMD and other indicators that we measured. Now, we are now focusing based on the descriptive analysis that we've done, we are focusing on a target trial emulation. So we are emulating a trial using the electronic F data that we have. And based on the descriptive analysis that we've done, we are now focusing on only 3 of the medication, because the number of people who have been prescribed dabigatran and warfarin are very low. And these are some of the inclusion and exclusion criteria that we have for our target trial emulation. So we are including individuals who have been diagnosed with atrial fibrillation age 75 to 100 years. And then there are other indicators that we are including as well. And our main primary outcome is ischemic stroke. And then secondary outcome is the major bleeding. And we'll have a follow-up period based on when they were, follow-up will start when they were dispensed the medication, and then it will end when they were diagnosed with ischemic stroke or they die, or the end of follow-up. And then we use the intention traits analysis and then cost regression models to implement some of the analysis that we want to do. Okay, thank you very much. I hope I stick to the 5 minutes time. Thank you.